morning, everyone. As Shannon said, my name is Lindsay Miles Hare. I'm the managing attorney for this project here at the DCBar Pro Bono program. Just as a brief practical issue, if you need to get in touch with me, you can flip to page 1. There's all of my information. I do want to say on the front end that you can call me or email me about anything. So before you get a case, while you have a case, after you have a case, it doesn't matter. Just give me a call. That's the number one thing. I want to make sure that I'm accessible to you. Thank you for being here. This is a really important project. It's maybe not the most attractive area of law. It doesn't have a law and order show, but it's really important. You'll see in the overview on page 1 why that is. But the basic gist is that for the clients of this project, this can make a big difference. Maybe they have medical debt that's preventing them from doing important things in their lives. Maybe they need treatment that they can't have access to. Maybe their kid needs treatment that they can't have access to. And I can tell you that some of our volunteers have really personal connections to the work that they do here because they've been in that situation. So thank you for being here, and thank you in advance for helping somebody who really does need you. That being said, I think you'll notice throughout the training today that we do have something for everybody. There are going to be cases that will come up for litigators who want to get in court or who want to fight with hospitals, and there are going to be cases for non-litigators whose skill sets may be, reviewing paperwork and writing letters and keeping good tabs on bills and that sort of thing. So, if you're thinking throughout the training, is there going to be the right kind of case for me? The answer is probably yes. We'll find you something. So you might be wondering how you get a case. That's not covered so much in the manual. It's pretty easy, pretty straightforward. After the training today, we're going to put everybody on a list of interested volunteers. We're going to open intakes. They had been sort of trickling in over the past few months, but the project had been slow while I sort of took over the position and got up to speed. So now that I'm here, now that we've got the manual, the support of our wonderful faculty and the training, we're ready to open the floodgates. So you'll go on a list. We'll start taking intakes or referrals, and then we'll start matching clients with attorneys. So you'll get a call from me or an email once a case comes up that we think would be a good fit for you, and you can let me know at that point if you're interested. Just on a practical level, it's good to let me know if now is a particularly busy time in your life, or if 3 months from now you've got a major trial or something like that. Just let me know so that I can account for that when we're handing out cases. And also know that it may be a bit of a wait, and that's not because we've forgotten about you. It's just because the sources that we get referrals from those clinics, et cetera, happen at different times. So this isn't the sort of thing where somebody can come off the street to the front desk and say, I can't get this covered. Can you help me out? What happens is these folks are going to legal service providers. They're going to the DCBar Pro Bono programs, advocacy and justice clinic, advice and referral clinic, and then they're getting referred to our project. So it's going to take time, but we'll find you something. We're happy to, and we're happy that you're here. Again, I'm so pleased that our faculty is here. This is going to be wonderful. And there's one final thing, which is if you have any questions about malpractice insurance, you should know that our malpractice insurance will cover all of our volunteers. So if you're barred and you're taking a case through us, you're fine. Okay? And that also extends to if you've got non-lawyer assistants. So there are folks who volunteer and their paralegals might be doing some of the work. That's covered too.
My name's Andrew Patterson. I'm a supervising attorney with the Legal Aid Society of DC, and I just wanted to briefly talk about this training in detail, sort of why we're doing it and what the objective is. So this is something that we see a lot of at the Legal Aid Society. I mean, Washington, D.C. has done a really good job of expanding coverage to individuals, health insurance coverage to individuals. Oftentimes that is wonderful, but sometimes it doesn't work as well as it should. Sometimes people, despite being enrolled in Medicaid or in another health insurance that they qualify for, they may not be getting access to the care that they are entitled to. Sometimes people who qualify for these programs are not actually enrolled in the programs. And so the idea behind this training is to help identify what people will qualify for in terms of their health coverage. And then once they're in the health coverage that they qualify for, what are some of the issues that they're going to face in terms of actually accessing the care that we need, that they need. Two of the main things that I think the presentations are going to focus on are, number one, when people are trying to access specific health services, what are some of the barriers that come up and what are some ways that you can address those barriers? And number two, when people have received health care coverage and they're receiving medical bills that they probably shouldn't be receiving because their insurance should be paying at least part, if not all of that, what are the ways that we can help people in those situations? And so David is going to start us off. He's going to talk about the exciting world of Medicare. And then I'm going to follow. I'm going to talk a little bit. So as folks are, I'm sure, aware, there have been a lot of changes to public health insurance through the Affordable Care Act, commonly called Obamacare. I'm going to talk a little bit about some of the changes that have been made to Medicaid in that specific context, and then also what the DC exchange coverage looks like. A lot of that is really complicated. I'm not going to spend too much time on that. Most of my presentation is going to focus on DC Medicaid and the DC Healthcare Alliance, which are two programs for low-income people who reside in the district. We will then have lunch, and then Patricia Smith is going to talk about some of the same issues, but in the private insurance context, and some of what she talks about is going to be applicable to people who are enrolled in private health insurance through the DC exchange. And then finally, Reed Henderson will conclude by talking about some consumer protection aspects, some aspects of consumer law that may apply to these situations as sort of another tool in the proverbial tool belt about how to approach some of these issues that clients may present with.
My name is David Lipschutz. I'm a senior policy attorney at the Center for Medicare Advocacy. We are a nonprofit organization that advocates on behalf of Medicare beneficiaries. We have an office in Connecticut and also an office here in DC where we advocate for policy changes that are hopefully in the best interest of Medicare beneficiaries. Over the next hour or so, we're going to provide a broad overview of the Medicare program, walk through the different parts, A through D, touch on some of the programs that are available for low-income Medicare beneficiaries, with the purpose of hopefully providing folks with enough tools to begin issue spotting when clients present to you with medical bills, if they have Medicare coverage. Hopefully, this will provide a very brief and very limited introduction to Medicare coverage that'll allow you to say, oh, wait a minute, this person has Medicare, and this is the bill in question. Has that bill been submitted to Medicare? Is this their cost sharing that's left over from what Medicare already paid? Are they in a Medicare Advantage plan, which means we don't deal with Medicare, really, we deal with that plan first. All of these questions will not likely be answered in the course of an hour, but again, will hopefully start the thought process and allow you to begin to assist your clients. And I think, you know, as Lindsay and Andrew said, it's I think all of you deserve a big thank you for even being here, not just for the rain. And I slipped twice on my way over here, and I was wondering, you know, since we're dealing with a room full of attorneys, if I knew that my shoes are particularly slippery and yet I wore them on a wet day, what type of tort liability would I be able to impose on any building that had very slippery sidewalks in front? And I figured that would probably be too far-fetched from the topic of question, so I will stop that line of reasoning. All right, Medicare. Medicare is really our nation's flagship insurance program. It is by and large beloved by those who have it, yet it also remains in the crosshairs and active in the debate among policymakers here in DC, in large part because of the share of the federal budget that the program takes up. The Medicare program is neither free nor is it comprehensive. A lot of people have the assumption then that when they get on Medicare, it's going to cover all of their health needs and people will not have any out-of-pocket expenses. This is simply not the case. Medicare was built on an acute care model in 1965 when it was introduced and passed. And that means that it was designed initially to try to provide coverage to people when things went wrong. When someone got injured, when someone developed an illness, it was reactive. It meant to provide coverage if you had to be hospitalized or had to go in a skilled nursing facility. Gradually over the years, Medicare is changing its orientation to also try to provide preventive services, to try to prevent people from getting sick, which I think is a welcome development that has been helped along a bit by the Affordable Care Act. So Medicare covers some of the cost of some health care. The parameters essentially are that the care must be medically reasonable and necessary. That's pretty much the bottom line in the Medicare statute. And the ultimate litmus test in Medicare is a given service reasonable and necessary. And sometimes the rules won't be absolutely spelled out. Sometimes there will be wiggle room within whatever coverage area you're dealing with. And you, if you're representing an individual, particularly in a Medicare appeal, will have to make the case that a particular service is medically reasonable and necessary. The care must be to treat an illness or injury, diagnosis, treatment, or rehabilitation. There's limited preventive coverage, as we noted, but it is expanding, and there are associated copays, deductibles, and premiums. We're going to walk through some of Medicare's cost sharing that are associated with Part A and B services, but just know that most people don't actually pay the cost sharing amounts that we're going to go over. Most people, as we'll discuss later, have Medicare plus something else. That means they have coverage in addition to just traditional Medicare, which means they usually don't pay the cost sharing that we're going to talk about, but it's important to know what that is for purposes of determining an individual's liability for any medical claims. How does someone become eligible for Medicare? There are generally three ways. Most people become eligible for Medicare upon turning age 65 based upon their work history or the work history of a spouse. Someone generally needs 40 quarters of work, which is roughly 10 years of work, in order to be eligible for Part A for free, that we'll talk about in a moment. Now, the full retirement age for Medicare for Social Security is age 66. You can draw early Social Security cash benefits at age 62. You'll get a lesser amount than if you waited until full retirement age. But now, retirement age is creeping up from 65 to 67 as the law currently stands. And right now, I think it's at age 66. So you have a lot of people who become eligible for Medicare the month they turn 65, but aren't yet drawing down Social Security benefits. It used to be that when a person turned 65, they got both their Social Security cash benefits and Medicare at the same time. Everything went smoothly, no problems, no questions. Now, because there is that delay in full retirement age, oftentimes people must actively apply for Medicare. And the time period that most people actively apply for Medicare is a 7-month window surrounding their 65th birthday. There's 3 months before the month of their 65th birthday, the month of their 65th birthday, and the 3 months afterwards. Unfortunately, Medicare beneficiaries must make the most complex decisions about their health insurance coverage when they have the least information and experience with the program, is right when they're first becoming eligible for Medicare. Another way to become eligible for Medicare is Medicare is available to certain individuals with disabilities. Another common misperception is if I'm an individual with a disability, I automatically get Medicare coverage. That is not the case. Eligibility for Medicare based upon disability is tied usually to some type of work history, primarily through the receipt of Social Security Disability Insurance, or SSDI. Usually an individual has to have built a work history and then subsequently has been found to have a disability and then found eligible for SSDI, and then they have to wait 2 years after that before their Medicare coverage kicks in. So they're roughly 13 to 15% of all Medicare beneficiaries are individuals under 65 with disabilities who are eligible for Medicare on the basis of being awarded SSDI. That waiting period, yes ma'am, sorry?
What is SSDI?
SSDI is Social Security Disability Insurance, sometimes called just straight disability insurance, but it's Social Security Disability Insurance. It's a cash benefit that's available to people who've paid in a certain amount to the Social Security system, but have been found to have been disabled, and renders them unable to perform certain work and thus eligible for this cash benefit.
They have to wait 2 years to get Medicare?
Yes, and most individuals who have SSDI must wait 2 years before Medicare coverage kicks in. The question, why is this so? To save money. There's no other answer to it, is to save money for 2 years where you have what can be individuals with significant illness that in the past have gone long periods of time, including this 2 years, without insurance until their Medicare coverage kicks in. It's simply a budgetary savings. Now with the Affordable Care Act and expanded access to insurance, many people will be able to fill in coverage during that 2 years through the exchanges, so they won't be without coverage altogether.
Is it only for the disabled person? Or
I'm sorry, ma'am?
is the coverage only for the disabled person?
The coverage, that's one way of becoming eligible for Medicare coverage. Most people become eligible for Medicare when they're 65. If an individual is eligible for SSDI as an individual with a disability, Social Security Disability Insurance, that will trigger Medicare eligibility, but for most people that'll be 2 years away. There are other potential ways that individuals with disabilities can get health insurance coverage. I think Andrew's probably going to touch on the Medicaid path to potentially getting insurance. Now we have the health insurance exchanges through which people can obtain coverage without pre-existing condition exclusions and things like that. So the universe is expanding, but for purposes of Medicare, it is really limited to people who have SSDI. There's one, I'm going to make one more point and then I'll get to your question in the back. There's one group of people who do not have to wait that 2 year period, and those are individuals with amyotrophic lateral sclerosis, also known as ALS, also known as Lou Gehrig's disease. This is one group of people who can get Medicare right away without waiting that 2 year period. Yes, ma'am, there's a question in the back.
Is there a required contribution for you to be eligible for Medicare under disability? Would you have had to be working for a required period?
Yeah.
What's that?
The question for folks on the videotape is there a required contribution in order to be eligible for Medicare for an individual under 65 with disabilities? Do you have to have paid in for a certain period of time to Social Security? And the answer is yes. An individual, I don't think it's quite the 40 quarters or 10 years that someone has to pay in before they're eligible for Medicare upon turning 65, but there is a requirement of work history. Used to be Social Security sent out these annual statements saying, based upon your work history, you are now eligible. If you become disabled for SSDI, you will be eligible for Medicare, but Social Security stopped sending those out. There's efforts to try to get that reinstated. But yes, there is a work history requirement for the most part. There are some very narrow exceptions where an adult disabled child can be eligible upon a parent's work record, but those are very rare. If you come across these situations, please feel free to reach out. And each one of these things that we go over today, if your mind works like a laptop computer, has a drop-down menu of further details to go into. If you hit on this topic, there's a whole subset of details and exceptions there, and there's a whole subset of details and exceptions to each of those details and exceptions. So we'll try to keep it as broad as possible and as comprehensive, but just know that there's no way we can cover all the permutations of Medicare coverage within this hour. Question? Yes, and then I'll get to you. Yes.
Just in general, where do spouses and children fit into the drop-down menus here?
The question is, where do spouses and children in general fall down in these categories with respect to eligibility for Medicare? For individuals age 65 and over, It's based upon, Medicare eligibility is based largely upon an individual's work history. So a worker who's working has paid 10 years, 40 quarters into the system. Spouses can be eligible based upon their spouse's work history. So say a spouse at home can be eligible for his or her spouse's benefits and thus be eligible for Medicare. There are rules for certain, you have to be married to someone for a certain period of time. I think it's actually only a year to be eligible for their spouse's work history. If a couple divorces, I think that couple had to have been married for at least 10 years before that person can be eligible based upon their spouse's work record. For purposes of children, it is a very rare occurrence, and I think it usually comes up in the last major category of Medicare eligibility, individuals with end-stage renal disease. Really, that's people with end-stage renal disease is really the only category of people that you'll see that includes children that are on Medicare coverage. If you have a child with end-stage renal disease, also known as kidney disease or kidney failure, largely that person will be eligible for Medicare based upon his or her parents' eligibility. I think there are a couple other narrow exceptions that I can't immediately pull up, but they are there.
Thank you.
So again, the categories: age 65 or over, an individual who's eligible for SSDI, individual under 65, and an individual with end-stage renal disease. That's someone who either requires a kidney transplant or has undergone at least 3 months of kidney dialysis. Coverage for Medicare based upon end-stage renal disease, or ESRD, is limited in time. It will expire roughly 3 years after a successful kidney transplant. And there are a whole host of issues surrounding individuals with ESRD who go on Medicare and need subsequent immunosuppressive drug coverage the rest of their life. And there are tricky rules about whether or not someone has Medicare at the time they undergo the transplantation and whether or not that entitles them to coverage of immunosuppressive drugs through Medicare in the future. So that ESRD and Medicare is its own universe. This is one group of folks that really get the short end of the stick when it comes to Medicare. As we'll see later, that's the one group of people who do not have a right to enroll in a private Medicare Advantage plan, like an HMO or PPO. These folks can be discriminated against based upon their health condition. It's legal discrimination within Medicare, really one of the only places where it still exists. I think there was another, yes, sir.
Do you know how many quarters you need to work in order to be eligible for SSDI? Or does that vary based on age?
For SSDI, I don't know. For age-related Medicare eligibility, it's 40 quarters. For SSDI, I'm not sure. It might depend in part on age, in part on income. And I'm sure there's a table on the Social Security website that probably lays out exactly how long someone has to work, but I don't know the direct answer to that question.
For SSDI, it's generally 10, you have to have worked for 5 of the previous 10 years or 20 of the last 40 work quarters. So if someone's applying for SSDI, they'll go to the Social Security Administration and Social Security will look at their work history. And looking back for 10 years, if there's a cumulative total of 5 years in which they were working and paying Social Security taxes, then they will be eligible for SSDI on the basis of their work history. They'll still have to prove up their disability, but they'll qualify. That's the qualification based on work history.
So it sounds like a minimum of 20 quarters.
Yes, 20 quarters within the last 40 quarters, so they have to be relatively recent too.
Okay. And then follow-up question on that. During that 2-year waiting period, would you be eligible for cash benefits as a SSDI recipient? I mean, you may not be eligible for Medicare, but...
Yeah, the question is for folks under 65 with a disability who are found eligible for SSDI and they're in that 2-year wait period before Medicare coverage kicks in, is that person entitled to a cash benefit? Yes. Once they're awarded eligible for SSDI, I think there's a 5-month gap or something where they have to wait before the cash benefit actually starts, but it's that 2-year period where they are entitled to and receiving the cash benefit, that they still have to wait for Medicare coverage, but at least they have the cash benefit during that time.
Okay, and then maybe I'm getting ahead of you, but I know there's Part A is usually free and Part B is a premium and Part D is a premium. And so if you're on SSDI, when that kicks in, would you have to pay that Part B premium? And
The question is, there with the associated premiums or premiums associated with Medicare, does an individual receiving SSDI, the cash benefit, have to pay those premiums? And the general answer is yes. Everyone with Medicare has to pay the associated premiums unless an individual is low income enough to qualify for one of the programs that can help assist an individual with paying for the premiums. In general, I think the SSDI benefit rate is usually above the Medicare Savings Programs level. So generally, people do have to pay, but anytime, and we'll get to this a little later, anytime you come across an individual that you're assisting who is relatively low income and having problems paying his or her premiums, it's always worth your while to see if that person might be eligible for a Medicare Savings Program that can help them pay for some of their premiums. And as Andrew will touch on, DC here has a very generous, comparatively, program that can help people pay their Medicare premiums.
Right, that's right. And just one other point to go back to your second question. During that 2-year waiting period, when people when they have their SSDI, but they're still waiting on their Medicare, they can still qualify for Medicaid during that time period. So in DC, which I'm going to talk about, the income limits for Medicaid are pretty generous. So a lot of people will be on Medicaid while they're waiting for their Medicare to kick in. So there usually is some kind of option for low-income SSDI recipients to get health insurance, even though their Medicare hasn't fully kicked in.
The Medicare program is roughly broken down into 4 parts: A, B, C, and D. And these letters got their name from where they appear in Title 18 of the Social Security Act. So Part A of Title 18 has to deal with everything that we know of as Part A of Medicare, et cetera. The Parts A and B form what's often known as traditional Medicare. They're really, A and B are the core of the Medicare program. Now, people have Parts A and B and nothing else. They are known to have traditional Medicare. It's also called original Medicare, sometimes called fee-for-service Medicare, although the Medicare program really is moving away from fee-for-service. The other parts, Parts C and D, are relatively new and are private options to obtain Medicare-related coverage. And we'll walk through each of these. We're going to walk through A, B, C, and D. But this just kind of sets up our discussion. The different parts of Medicare really interact with other types of insurance in different ways, and there are way too many permutations to try to cover in an hour. But much of the analysis and trying to assist individuals who have outstanding medical bills is based upon what an individual has. What do you have now? Let me see your Medicare card. Do you have A and B? Do you have something else? Do you have a Medicare Advantage plan? One of the first questions is, what do you have as far as your insurance? Now, this isn't on the slide, but there are, of course, different entities that one must deal with depending upon the particular Medicare issue. Social Security, for example, the Social Security Administration, or SSA, handles Medicare eligibility, enrollment, and premium payment for Parts A and B. But pretty much everything else in administration of the program is done through the Centers for Medicare and Medicaid Services, or otherwise known as CMS. It should be CMMS, but they got cute and abbreviated it to CMS. CMS, the Centers for Medicare and Medicaid Services, in turn contracts out a lot of their day-to-day oversight and administration of the Medicare program to a host of different insurance companies, largely, that administer the actual benefit. So if you are dealing with a Medicare bill, you will very likely be, if you try 1-800-Medicare and don't get an answer, you will very likely be dealing with one of the many Medicare contractors that come in all sorts of shapes, sizes, and different names. Usually, correspondence from these Medicare contractors will have the Medicare name somewhere on there, or say CMS, and then add the insurance name onto it. But it's impossible to keep up with all the different ones and the different scenarios, that you largely have to see the paperwork to know what different Medicare contractor you're dealing with, and sometimes it'll vary even within the same geographic area, even with the same type of provider. But in general, CMS, Centers for Medicare and Medicaid Services, is the parent agency under the Federal Department of Health and Human Services that administers the Medicare program. Social Security Administration handles Part A and B, eligibility, enrollment, and premium payment. So let's start with Part A of Medicare. Medicare Part A broadly covers 4 general areas of coverage. It covers hospital care up to a limited duration, as we'll talk about, skilled nursing facility care, or SNF, one of the more colorful acronyms in the medical world, stands for skilled nursing facility, home health care, often abbreviated as HH, and hospice care. This is the universe of things that are covered under Part A of Medicare. As we'll see a little later, Part B covers a much broader universe of things, and it's not always clear whether or not something is actually covered under Part B. Most people do not pay premiums for Part A of Medicare. If you meet that work requirement, if you're eligible for Social Security retirement, if you're eligible for SSDI, that entitles you to premium-free Part A. People, by and large, do not pay premiums for Part A. They do for Part B, that we'll get to in a few minutes. That is not to say, however, that someone who does not have enough quarters under Social Security cannot get Medicare. There's a whole separate set of rules for a group of people that are known as voluntary enrollees. If you come across someone who, they have to be at least age 65, they have to either be a citizen or a lawful permanent resident who's resided in the country for at least 5 years, that person can buy into Medicare. If they don't have any work history, they will face very high Part A premiums in the neighborhood of $300 to $400 a month. If an individual doesn't have to do anything with immigration status, but an individual is 65 or over, and he or she does not have the requisite 40 quarters, or his or her spouse does not have the requisite quarters, there's a little bit of a sliding scale depending upon how many quarters someone has to be able to buy into Medicare and pay Medicare premiums. Usually not an issue that comes up, but be aware, if you do encounter someone that does have to pay Medicare Part A premiums, there is one of the programs that we'll talk about later that's available to individuals for low income that can cover the Part A premium cost, and that's the qualified Medicare beneficiary. We'll touch on this, and again, Andrew will touch on it also, I think, during your part, and DC's, again, rather generous expansion of coverage. Yes, ma'am?
I'm pretty new to this, but what is a premium? What is a premium? Is it a monthly fee that you're paying every
Yes,
month?
the question, and that's the danger with really talking about any kind of health coverage, health policy, is the terminology is sometimes conflicting, confusing, cross purposes. The premium, when I talk about premium, that's a monthly amount that is due from an individual to be paid to the program or a particular, say, insurance company that's administering the benefits. So in this case, when we talk about Part A or Part B premiums, that's a monthly bill, so to speak, that you must pay in order to have that coverage. So again, for Part A, most people don't pay premiums for Part A. That's one of the benefits that you get through having the requisite work history, is you get your Part A premium free. As long as we're on terminology, one of the often confusing differences in terms is coinsurance versus co-pays. Copay, the term generally refers to a set dollar amount. Like, I'm under my health plan, I go to the doctor and I have a copay of $40 every time I go, or $45, whatever it is, every time I go to my primary care physician. I know that's the amount I have to pay, it's my copay. Coinsurance, on the other hand, is a percentage amount of the overall cost of care. As we'll see in a minute, Part B generally charges a coinsurance. In other words, it charges 20% of a given Medicare covered service, meaning you're going to be responsible for paying 20% of whatever the cost of that given service is. If the cost is $100, Medicare pays $80, you pay 20. If the cost is $200, you pay $40 as 20% of the insurance. But definitely a distinction between those two terms. Again, the figures we're about to run through, the dollar amounts that are charged for the services under Parts A and B, most people do not actually pay these because they have Medicare plus something else, but it is important to know what these amounts are as a reference point for purposes of figuring out who owes what and what is being charged. Let's talk a little bit about each of these individual types of coverage. Hospital coverage under Part A of Medicare, the length of coverage, the cost-sharing liability that someone has hinge on the concept known as a benefit period that we will touch on in a moment. But for now, under Medicare, there is a set number of days that Medicare will cover in the hospital. Medicare will not cover someone indefinitely in the hospital. It is rare that someone needs to be in the hospital more than 90 days, but Medicare, by and large, will cover the first 90 days in a hospital. If someone is unfortunate enough that they need to be in the hospital past 90 days, there are what are known as 60 lifetime reserve days. Think of these as days that you have in your Medicare bank that you can use only once. It will be a rare case that someone will use up all their lifetime reserve days, but it does happen. So if someone's in a hospital more than 90 days, they have 60 days when they first become eligible for Medicare of lifetime reserve days that they can use if they go past day 90 to add additional coverage. They burn through that, and they're in the hospital more than 90 days, they're responsible for all the attendant costs. Yes?
Are there any exceptions for this when, say, somebody is getting Medicare as a child and then uses it again when they're older?
That's a great question. The question is there any exceptions to this? Say someone is getting Medicare when they're younger and then gets Medicare again later on. In general, if you have Medicare and you're under 65 and there are any things that attach to you or that coverage, like for example, say you have a late enrollment penalty because you failed to enroll when you were first eligible. Once you hit 65, that penalty goes away. A refresh button is pressed. I've never gotten that question though about whether or not the lifetime reserve days are, so I assume it's the same concept, but I don't know for sure. But that's a great question that it's going to bother me and I'm going to have to go look up now.
I want to know how it could occur. You mean a younger person was disabled
Yeah.
and then got well
there could
and lived to be 65?
there could be a really sick kid who gets a transplant and eventually does well and then lives to be 65 and then is eligible again. It's a very theoretical question, but
But
I'm
the
just
kid would
wondering.
only have it if he had had 5 years of work on the social.
No, I don't think so.
Yes, that's the only way the kid could
No,
have gotten
if the kid had end stage renal disease,
Oh,
for
it-
example.
Yeah.
Well, he's gone.
Yeah. So
It's probably not gonna happen,
Right.
so, and it sounds like we don't know the answer anyways. We think it will
yeah,
probably
there's an
be
answer, I
that.
just don't know it.
Yeah, okay, thank you.
Sure.
It was very-
So-
I'd be so working about how did it come about, but I never get to the answer.
Yes, ma'am. Question
It says
back.
days available per benefit period. How long is each benefit period?
Yeah, we're going to get to that in a sec. We're just setting up the kind of the general, the number of days, and then what you got to pay for them, and then we're next going to turn to the benefit period. The cost sharing under traditional Medicare, someone who doesn't have anything else, there is what's known as a first day hospital deductible. 2014 of $1,216. That is an amount that you have to pay if you spend the night in the hospital. Medicare will cover all hospital-related expenses for the next 60 days. If you spend one night in the hospital or 59, nights in the hospital, you're responsible for that first day hospital deductible, $1,216. Medicare does not charge after that time. For the first 60 days, someone has to spend in the hospital. Rare, but it does happen. If someone is in the hospital beyond 60 days, then a copayment does kick in for the next number of days. It's $304 per day this year, up till day 90. If someone has to use one of their use one time only 60 lifetime reserve days, they have to pay $608 as part of that. Now, Part A of Medicare covers the charges in the hospital. That does not always mean that Part A covers attendant physician services. Physician services are billed under Part B of Medicare, and that's a common area that comes up for folks. They're hospitalized, they have Medicare, the claims are submitted, they think that Medicare is covering everything, and then lo and behold, they get a bill from an anesthesiologist down the road for that hospital stay that they thought was otherwise covered. And the issue is, well, was that billed to Medicare? Is that above and beyond what Medicare has already paid? And it opens up a whole host of questions. The concept of a benefit period, we're going to touch on to your question in the back after we talk about skilled nursing facility coverage, because the two are related. But one final note on hospitals. There is a current issue in the Medicare world and beyond the Medicare world surrounding hospital coverage that is having a profoundly negative impact on Medicare beneficiaries, and which is my main concern, and to another extent, hospital finances. In the hospital world, if we have time to talk about this at the end, there's a growing use of this concept known as observation status or observation services. This is this concept that hospitals have been using at an ever increasing rate, that where essentially they have a person in a hospital, for all intents and purposes, looks like every other hospital beneficiary. They're wearing their little hospital gown, eating the hospital food, largely getting the same hospital services that an inpatient is, but the hospital calls that person an outpatient. They're an inpatient outpatient. They're a person who's in the hospital spending days or multiple days or weeks in the hospital, but is nonetheless called an outpatient under observation status. Some of the genesis of this is that some of the entities that pay hospitals, including Medicare, sometimes believe that people who are in the hospital don't need that hospital level of care. They still need to be monitored, but it's not a full inpatient level of care, so let's call it something else. Observation status, that person is an outpatient, even though they might not know. When it comes to Medicare, as we'll see with skilled nursing facility coverage, the biggest threat to Medicare beneficiaries is that if they are in a hospital and they are deemed to be under observation services, they will largely not be eligible for any skilled nursing facility services after that hospital stay. As we'll talk about in a minute, Medicare covers some care in the skilled nursing facility setting. There are some requirements for Medicare to cover that care, and one of those requirements, as we'll see in the next slide, I'm getting ahead of myself for a minute, is that a person must have spent 3 days as an inpatient in a hospital prior to a skilled nursing facility stay. Days spent under observation status are treated as an outpatient stay, meaning those days make someone ineligible for subsequent skilled nursing facility coverage. We get calls about this on a daily basis. We have sued the Medicare program about this. We are pushing legislation in Congress to try to address this. My colleague is testifying before the Ways and Means Committee on Tuesday. This is an enormous problem, and if you're going to deal with the Medicare billing issue, is likely to be one of the issues that comes up. Again, we given our limited time and the scope of things that we have to cover today, I just wanted to get it on your radar. Our website has a host of materials on this, including self-help packets to help people walk through appealing this and to try to get their claims covered so they can get some stay in nursing. So I think there are a couple of questions. We'll try to take them before moving on. I think, yes, ma'am, you had a question?
Yes. Is there a requirement for disclosure to the patient before being admitted? So that at least they would have an idea of their status for the time that they are in the facility?
Is there a requirement to essentially notify the patient? Is that what you're saying? The short answer is no.
Uh-oh.
There's a form that Medicare program produced that hospitals sometimes use that tell people, hey, you might be an inpatient or outpatient. You should ask. New York State recently passed a law that requires hospitals there to inform people if they are under observation status. But one of the big issues in observation status is you generally have no notice about it. If you find out about it, you find out about it after the fact, maybe when you're at the nursing facility, maybe as you're on your way out the door of the hospital, and there is no mechanism to appeal the fact that you are in observation status. There's an entire industry that has cropped up around this that consult with hospitals, that use proprietary software to help them figure out what they think Medicare is going to decide about whether or not someone's an inpatient or outpatient. The hospitals overcompensate their fear of being audited after the fact and default people almost to observation status, which creates tremendous problems for beneficiaries. The largest one we see is no skilled nursing facility coverage. I think there's one more question, then I'll move on.
You may not know this, but does the doctor determine they're in observation? Who is documenting this?
The question is, does a doctor determine whether or not someone is in observation status? That would make total sense. It would make sense that the treating physician would have the discretion to say, I think this person is sick enough that he or she should be admitted as an inpatient. The short answer is sort of. It used to be that the doctor's decision held, and the hospital had to follow that. Then the rules changed, and the hospitals have the ability to second guess the physicians. The physician says this person is an inpatient, the hospital can say no, they're not. And now there's this, I know this is being videotaped, so I'm trying to watch my language and what I say critically, but there is a less than helpful rule out right now with respect to Medicare coverage called the 2 midnights rule that creates all sorts of presumptions when a person presents at the hospital. If he or she is determined to be in the hospital for at least 2 midnights before they actually stay there that long, then there's a presumption that the person will be an inpatient after that time. But if they're not going to be there 2 midnights, then there's a presumption that the person is not going to be in
2 midnights?
2 midnight rule, right, which is different from the 3 midnight rule that we have for Medicare coverage.
You presume after 2 midnights, you're inpatient.
That's the default presumption under this rule. However, the Medicare program has suspended enforcement of this rule through March of next year as of now because
That's a little ridiculous.
it's a morass and people are having trouble figuring it out, having trouble enforcing it. There are all sorts of conflicting parties going back and forth, leading to tremendous backlogs in the entire Medicare appeals process because of these payment issues. But I digress. I know there are a bunch of questions. I
Just one.
got an extra 20 minutes, but I'm already running behind and where I need to be, so I will move on. If there's time at the end, happy to talk more about observation status. This is one of the issues that we are paying a lot of attention to and a very real issue for Medicare beneficiaries. So Medicare coverage of skilled nursing facility stays. It is another common misbelief that Medicare will cover all care in a nursing facility indefinitely. A lot of people just assume once they're on Medicare, they need to go to a nursing facility, Medicare will cover them. This is not the case. Medicare coverage of stays in nursing facilities are limited in both duration and for the type of care that is covered. In order for, or Medicare will cover up to 100 days in a skilled nursing facility. Medicare coverage will not be indefinite, even if a person meets all the requisite coverage criteria that is discussed on the next slide. For the first 20 days of stays in nursing facilities, Medicare does not charge cost-sharing amounts, but starting at day 21, Medicare 2014 charges $152 per day up until 100 days if someone uses that amount of time. And anyone take a wild guess at what the average or when many people tend to be discharged from skilled nursing facilities? Anyone take a wild guess around what day? How many days do people tend to be?
102?
102? Oh, close. I think a lot of people would love to have that. Right around 20 days. A lot of people start to get discharged from the nursing facility once the cost-sharing obligation, once the costs aren't all being paid by the Medicare program and the cost-sharing liability attaches to an individual. Individuals are harder to collect from. Other entities don't always pay on time. It's not always the case, of course, but it does come up quite frequently. The lengths of stay sometimes revolve around the lengths of, or how payment is structured. So that's the timing and the costs for Medicare coverage in a skilled nursing facility. What else must be met? There must be a 3-day qualifying hospital stay, as we just talked about. That must be an inpatient stay. A stay under observation status is treated as an outpatient stay. You could spend 3 weeks in the hospital under observation status, and that will not qualify you for subsequent skilled nursing facility care under Medicare. Also, in order for Medicare to cover any care in the nursing facility, there must be daily skilled care. The care that an individual receives must rise to a certain level. It has to be beyond just assistance with the activities of daily living. They must require the skilled services of trained medical technicians, whether or not it's a nurse, whether or not it's a physical, speech, or occupational therapist. They must require daily skilled care. If a person is in a skilled nursing facility because they need some type of therapy, and it's physical, speech, or occupational therapy, that daily requirement is a little more fuzzy. You can be getting 5 days of therapy. That doesn't have to be every day of the week, but you have to at least be getting 5 days of therapy in order for Medicare to cover your stay. The care must be medically reasonable and necessary, and it is limited to 100 days. It is rare that someone will have a Medicare-covered stay of 100 days, but if someone continues to meet that eligibility criteria, it's daily skilled care. Even if at day 101, if that person still needs that nursing facility care just as much as they did the day before, Medicare coverage ends. It is a benefit that is limited in duration. The person must be getting daily skilled care. Some Medicare Advantage plans and other types of plans will cover additional days if someone is in a nursing facility longer than that, but the Medicare criteria are limited, and people under the traditional Medicare program can't get more than 100 days. Yes?
Is the 100-day limitation, does it start over with every 3-day qualifying hospital stay?
That leads perfectly into the next slide. Your question, the question that was asked earlier in the back about what is a benefit period and when is this cost-sharing amount charged. These limits on coverage, up to generally the 90 days in the hospital, and the 100 days in a skilled nursing facility are not based upon the calendar year. They are based on an entirely different concept known as a benefit period, used to be called a spell of illness. You might hear them referred to as both. It works like this. A benefit period begins on the first day a beneficiary is admitted to the hospital and does not end until the beneficiary has not received a hospital or skilled nursing facility level of care for 60 consecutive days. That's a bunch of words. Let's use an example so we can make it a little more tangible. Say I was hospitalized on January 1st. I spend 10 days as an inpatient in the hospital. Forget about observation status and all that stuff. I'm firmly an inpatient in the hospital. And I need subsequent skilled nursing facility care, which is often common in Medicare. Depending upon what you're hospitalized for, what your condition is, oftentimes skilled nursing facility care is required afterwards, whether it's to rehabilitate from a broken bone or whatever the reason. I then enter the skilled nursing facility for 3 weeks, for 21 days, and then I'm discharged from the skilled nursing facility. Medicare covered my hospital stay. I had to pay my first day hospital deductible. Medicare covered my skilled nursing facility stay. I was at day 21, so I had 1 day of co-pays I had to pay. And I am discharged to home. If I am rehospitalized, if I have to go back to the hospital, or if I have to re-enter the SNF, less than 60 days after I'm discharged from the skilled nursing facility, the clock continues to run. If I go back to the hospital, I was in there 10 days, I start at day 11. If I go back to the skilled nursing facility, I was there 21 days, we start at day 22. If I am out of the hospital and the skilled nursing facility, and out of that, receiving that level of care for 60 days, then the clock refreshes and everything starts anew. Which means that if I'm rehospitalized 61 days afterwards, I have to pay that first day hospital deductible again. Everything is clocked with respect to the length of hospital coverage and eligibility for skilled nursing facility coverage on that benefit period. So that's one of the most tricky things to figure out if you're dealing with a beneficiary who has an outstanding bill that's hospital related or skilled nursing facility related. You almost have to draw out a timeline. Find out how long they were hospitalized, how long were they in the skilled nursing facility, go back beyond them. Did they have a prior hospitalization or prior skilled nursing facility stay that might factor into this, because that might determine what day they're on, what level of cost sharing they have, and whether or not they're eligible for the benefit at all. So it does, I hate math, but it does require a little math in situations like this. Yes, ma'am.
Beneficiary period, is it in any way related to the condition or diagnosis that led to the hospitalization? So in other words, you're in hospital 10 days, you come home, and 15 days later you go back, but it's for an unrelated medical issue.
That's an excellent question. I think the general answer is no, but I would ask about the condition too, with respect to trying to assist beneficiaries through the appeals process and coverage process, because that issue might come up. So the short answer, I believe, is no.
Question.
Yes.
Are any of these benefit periods or durations of coverage dependent on calendar year periods? Doesn't seem like calendar year makes a difference.
For purposes of the benefit period and hospital and skilled nursing facility cost sharing and coverage, no. But for virtually everything else related to Medicare, yes. This is one area where the calendar days related to when you were first hospitalized and when you were in a nursing facility can refresh and can happen multiple times per year. We'll talk about in a minute, there's a Part B deductible that is annual. You only have to meet that once a year for any Part B services, but this is different. The benefit period concept is pretty much limited to the hospital and the skilled nursing facility setting. The third kind of coverage under Part A of Medicare is home health services. Another common misperception in the Medicare world is that Medicare, well, most people think Medicare will cover unlimited care in the nursing facility, which is not true. Most people correspondingly think Medicare won't cover any care in the home setting, which is also untrue. Medicare does offer some coverage in the home setting if certain conditions are met. And unlike the hospital stays or skilled nursing facility stays, under law, it is not limited in duration. In practice, it is significantly limited in duration. In order for Medicare to cover any care in the home setting, someone must require skilled care. Again, it must be the services of a licensed professional like a nurse or often a therapist, physical, speech, or occupational therapist. The nursing or skilled services must be intermittent, meaning it cannot be daily. If someone needs round-the-clock care or someone needs daily care, they're not going to qualify for Medicare home health coverage. The benefit is structured in such a way as to provide intermittent care. Every so often, the person comes in and provides a skilled service. No more than 35 hours per week combined nursing and aid services. If someone qualifies for Medicare home health coverage, they must require skilled services. However, if someone qualifies on that basis, the home health benefit can also pay for home health aid services, which is what we more traditionally think of as the type of care that people need in their home. They help with activities of daily living, such as eating, bathing, dressing, toileting, and things like that. If that's all someone needs, Medicare is not going to cover that. If someone needs the skilled care and they're getting that, they can be eligible for some of those additional home health aid services. One of the criteria for eligibility for Medicare home health services is that an individual must be homebound. That is a test, a threshold test for coverage of Medicare home health services. That means, in general, that leaving home is difficult and infrequent. It does not mean that a person must be bedbound or that they can't leave home. Sometimes this homebound requirement is interpreted too strictly. There are actually, there is some flexibility within the definition of homebound. It must take an individual, or must be a considerable and taxing effort for an individual to leave home. That does not mean that they cannot leave home. But in order to leave home, it requires the assistance of another person, of a device. They're not out of home for that long of a period of time. Some absences from the home do not count against this homebound requirement. For example, medical visits. You can go to 20 medical visits a week and still be considered homebound. Some things like a day adult health services will not count against this homebound requirement. If someone needs home health care services and they're being denied because there's been a finding or an opinion on the part of the home health agency or someone else that someone is not homebound, that's worth taking a look at. Is how much truth is there to that? Does the person, in fact, qualify under the homebound definition? Home health services. Yes, ma'am.
If someone is homebound and they do need daily care, then where would they get coverage for? Under, like, what health law, or where would you get coverage under?
That's the $64 billion question that I think policymakers have been grappling with for literally decades.
Because I'm just wondering, because I know there are situations where, like, somebody who had a stroke or something, needs somebody to feed them. I'm just wondering how they able to cover that medical nurse coming in and helping out. Like, where are they getting that medical coverage if not under Medicare?
It's largely just a patchwork. And oftentimes it's family members, family caregivers that have to provide that service themselves. If they can get some of these services covered through Medicare, great. If that person meets the qualification criteria for Medicaid, they might be able to get coverage through that. If that person has a long-term care insurance policy that is still in effect and covers the requisite amount of care, it's possible that person might get care through that avenue. There are some Medicaid-related programs and home and community-based services that's gradually expanding the type of care that people can get in the community as opposed to in institutional settings. But I mean, that question is a great question, and it really highlights a huge gap in coverage, healthcare coverage in our country. And there are blue ribbon panels that have been looking at this issue for decades. There are policymakers trying to push solutions to the problem of providing care for people in their home round the clock. And the short answer is there's no one route, there's no one type of insurance that will cover everybody for absolutely everything, and the default is often family members stepping in, and if they can afford to pay for caregivers, they do. If they can't, they render it themselves. If there's no other way, oftentimes people have to end up in an institutional setting. So I wish there was an easier answer to that question, but it's really a gap in our public policy. Yes, sir.
Once again, the same question. Who makes the determination of whether or not skilled care is required?
In the home health care setting, in order for Medicare to cover anything, there must be a plan of care. And that is usually a document that's drafted by a home health agency, but it must be reviewed and signed by a physician. Usually, the home health agency will put it together and give it to a doctor will sign, but the idea is a doctor is supposed to assess this person, say, this person requires skilled care intermittently in the home, and it is my order as a physician that this person gets it, and the home health agency is tasked with implementing that order. That can be second guessed. You know, the home health agency can terminate services. That could be subject to appeal. You could be a disagreement about whether services were reasonable and necessary. This is a rather cynical overgeneralization, but I think important to say in the context of medical billing. The way that a lot of services are paid for in Medicare, and probably across a lot of other healthcare settings, is that there are often incentives to terminate care prematurely. The way that providers are paid for services in order to reduce financial out-of-pocket risk, oftentimes there's an incentive for providers, and not all providers do this, but there's often incentive for providers to terminate care when someone is still eligible for them out of concern or fear that at the end of the day, whatever services are being rendered will not be paid for. So it's something to keep in mind. It's something that's hard to combat, particularly if you don't act right when those services are being terminated. Oftentimes when Medicare service is being terminated, there are some appeal rights right at that time, but if you miss that narrow window of time, then it's just a matter of later on, you know, trying to get that care somewhere else or paying for it out of pocket and seeing if you can get Medicare to reimburse it, which is a lot more difficult and timely prospect. But just be aware there are financial incentives, and providers will tell you, well, you know, if I think Medicare is not going to pay for this service, I'm not going to go out on a limb and provide it. I'm going to be prudent and render the type of care that I am, you know, confident Medicare will provide coverage for. And sometimes it is an argument between beneficiaries and their advocates and providers for ongoing care. Moving on to the last type of Part A coverage is hospice care. Hospice coverage under Medicare is designed to provide coverage for individuals who have been diagnosed with a terminal condition, which essentially means that a doctor has determined that the person likely has 6 months or less to live. If someone makes a hospice election under Medicare, it's an active election that they make. They choose to receive hospice services that are list is covered on the next page. And they essentially agree to forego care for whatever condition is making them terminal. For example, if someone has terminal cancer, they elect hospice coverage under Medicare, they are foregoing care to treat their terminal cancer. That does not mean that they're foregoing all medical care. They can have an unrelated condition. They can break their arm. They can, you know, develop something else that can be covered under Medicare, but treatment for their underlying terminal condition will not be covered. If a person makes a hospice election, he or she has the right to revoke it at any time. They can change their mind. They can say, wait a minute, I am going to try to fight this condition that I have, and I want treatment for it. The type of services that are available in hospice are just listed quickly here. I'm not sure how often hospice benefits might come up in the context of the clients that you're helping, but given time, I need to move on to Part B of Medicare because I still have C and D to get through too. And true to form, I've taken up too much time already. Part B of Medicare is, we just covered some services covered under Part A. There's 4 services. Part B of Medicare is much more like a general catch-all. There's a whole range of services that are covered under Part B. This is not an exhaustive list. The best way really to find out if something is covered under Part B of Medicare is to unfortunately dig in the weeds of the Medicare rules. There's on the CMS webpage, the Centers for Medicare and Medicaid Services at cms.hhs.gov. There is a Medicare coverage database that if you type in some keywords, it can provide a lot of information about what is covered under Medicare Part B. Medicare does not cover everything. There are some gaps in Medicare. Up until the Part D prescription drug benefit that came into effect in 2006, Medicare by and large didn't cover most prescription drugs. Part B does not cover most prescription drugs. Part B does cover drugs that are usually not self-administered, meaning usually drugs that are required to be administered by someone else in a doctor's office or other provider's office. There are sometimes disputes over whether Part B as in boy or Part D as in drug should be responsible for paying for a particular drug. But for our purposes now, Part B does not cover most prescription drugs, nor does Part B cover eyeglasses, except one pair after each cataract surgery, during which an intraocular lens is inserted. Part B does not cover hearing aids, nor does Part B cover most dental care. These are some pretty big holes in Medicare coverage and things that many Medicare beneficiaries could benefit from. So, Medicare beneficiaries either pay out of pocket for these things or they find some other type of insurance that can cover some of these things. As mentioned earlier, Medicare is slowly adding preventive services and shifting from acute care model where services are mostly reactive to when someone is injured or ill. They're adding preventive services, including an annual wellness visit. This is a potential pitfall here. Medicare now covers an annual wellness visit, but this does not equal a physical exam. It's a common misperception that people can get a physical exam covered by Medicare every year. That is not the case. Problems sometimes arise with annual wellness visits when something is found, too. If a clinician finds something and wants to order additional tests based upon what that clinician has found, sometimes those additional tests will not be covered in full. There will be some cost sharing associated with it. So there has been some confusion over Medicare coverage of a wellness visit and what has often been called zero cost sharing preventive services. Beneficiary costs under Part B of Medicare, there is a deductible. Annual deductible that is $147 this year. It was the same last year, and this is on a calendar basis. This is the deductible per year. If you need medical services January 2nd and it's at least $147, you pay that amount, and then Medicare Part B coverage kicks in for the rest of the year. The cost sharing or coinsurance for Part B services is generally 20%, meaning Medicare will cover 80% of the cost of a given charge, a Medicare allowable amount, they call it, and you as a beneficiary will be responsible for the remaining 20%. It's the typical 80-20 ratio that we often hear about with respect to Medicare cost sharing. This amount can be significant depending upon the service that someone uses. And as we'll discuss shortly, most people with Medicare have Medicare plus something else. Unlike Part A of Medicare, most people do pay a monthly Part B premium. If someone is getting Social Security, it's often taken out of their Social Security check, so oftentimes people don't even realize they're paying a monthly Part B premium. It is about $105 now, the same as last year. Higher income individuals will pay higher Part B premiums. If an individual earns $85,000, a couple $170,000 per year, their Part B premium will be greater. The Medicare costs or premiums for Part B are pegged at essentially 25% of overall Part B services. The higher income folks pay a larger share of that. That is Parts A and B, but that is not by a long shot the end of the story or the end of the materials that I was tasked to get through today. 90% of Medicare beneficiaries have Medicare plus something else. The vast majority of people do not have just Parts A and B of Medicare. So the inquiry does not end, but rather begins when someone says, I have Medicare. You have to find out exactly what they have. And oftentimes people do not know what they have. They say, I have Medicare, and that applies to traditional Medicare, it applies to Medicare Advantage, it applies to Medicare supplemental insurance policy, it applies to retiree coverage. You often have to physically sit down with the person, ask them to open up their wallet and lay out all their cards on a table and bring you all of their paperwork associated with their coverage and their bills. Then you might be able to piece together what type of insurance that person has, who you need to go to complain or try to resolve an issue, and how much an individual might owe. There are different kinds of insurance that interact differently with Medicare, and there are permutations for each one of these different types of coverage and how they interact with Medicare. There are manuals, chapters, guidance, ad nauseum written about these different types of insurance and how they interact with Medicare. This is extremely high-level ballpark overview, globalization, 1,000-foot view of Medicare and other types of insurance. There is employer-based insurance. Many people have employer-based insurance through their work. By definition, that's what employer-based insurance is. A lot of people continue to work after they become eligible for Medicare and hold on to the insurance that they have through their employer. There's a set of rules that applies there. If the employer is of a certain size, that employer insurance will continue to be the primary payer to Medicare. It will pay first. If someone retires and they stop working and their insurance either becomes COBRA, the insurance that you can get when you leave a job and don't have other insurance, and you can pay a lot more premiums than you were paying before, or that person retires and has retiree coverage, the equation changes. Almost always, COBRA and retiree coverage will be secondary to Medicare. Many, many people get tripped up over the transition in employer-based insurance from that which is based on current active employment to that which is no longer based on current active employment. A lot of people forego enrolling in Part B of Medicare when they have employer-based insurance that is based upon their current active employment, which people can do without a penalty. The idea is to encourage people to stick with the insurance that they have. It allows people not to pick up Part B, later on pick it up without penalty. However, a lot of people think the rules operate the same way once they retire. If someone has employer-based insurance and they are no longer working, they're about to retire, they're no longer working, they go on COBRA, the whole equation changes. They need to pick up Part B of Medicare. A lot of people fall through the cracks during this transition and end up being stuck with a lot of medical bills and no insurance coverage until the next time they can enroll in Medicare. It's a huge pitfall in the Medicare program. So again, the inquiry does not end at, yeah, I have coverage through my work. The next question is, are you still working, or is your spouse still working? Is it retiree coverage? What kind of coverage do you have? Some retiree insurance coordinates with Medicare. Some employers offer their retirees a supplement to Medicare coverage through a Medicare private plan. Sometimes that will dictate who you need to deal with when it comes to problems with Medicare bills. There's a type of insurance called Medicare supplemental insurance policies, also known as Medigap plans. These are private insurance policies that are designed to supplement traditional Medicare, the original Medicare program, and fill in some of the coverage gaps. These are standardized insurance policies organized by the letter of the alphabets, A through M, although now we're missing some because of changes in the law. But these are standardized policies where you can buy to supplement Medicare to pay for some of the cost sharing we talked about. And you can compare them just based on premium alone because of their standardization. There are some folks with military coverage, but Veterans Administration in Medicare works differently from TRICARE in Medicare. Veterans Administration coverage can be used independently of Medicare. You can use either Veterans Administration or Medicare. There's not generally a primary or secondary payer issue. TRICARE, however, TRICARE for Life, will act as a secondary payer to Medicare. Medicaid, the topic that Andrew will talk about next, is secondary to Medicare. There are a lot of individuals who have both Medicare and Medicaid. These folks are often referred to as being dually eligible for Medicare and Medicaid, or dual eligibles. There are different permutations that arise with people who are dually eligible. In some areas of the country, these folks are required to enroll in managed care plans that are administered by the state, sometimes it's administered by the county, sometimes they're totally independent scenarios. And I will defer to Andrew for exactly how dual eligibility functions here in the district. But again, it's a whole other level of complexity.
Question?
There are, yes.
I know you're trying to get through this, but on the Medicare supplement, Medigap, my understanding is that that's contingent on Medicare coverage, and then Medigap fills in the gaps. So, for example, so if Medicare doesn't cover home health or skilled nursing, the Medigap wouldn't fill that in. Is that correct?
Medigaps pay when Medicare pays. They pay the cost sharing and Medicare pays. They don't pay if Medicare doesn't pay. Some of the Medigap policies will add extra benefits like an extra days in the hospital or, coverage when you're traveling abroad for a limited time, but you're right. The Medigap policies will not step in if Medicare said, no, we're not covering this because it's not reasonable and necessary. The Medigaps are designed to fill in some of the cost-sharing gaps and in some cases expand some of the coverage that's not available in Medicare.
So if the SNF coverage isn't available because you're in observation status, the Medigap isn't going to pick it up.
That's right. The question is, so if you need skilled nursing facility care, but Medicare finds you ineligible because of the hospital's use of observation status, that is correct. The Medigap will not step in and provide that skilled nursing facility coverage because it bases its determination of coverage by and large on Medicare. If Medicare pays, then the Medigap will pay the cost sharing if that's amongst the scope of what it covers. If Medicare determines something is not medically reasonable and necessary, and Medicare says we're not going to pay this, the Medigap company will not step in and say, we got this one. They're designed specifically to fill in some of those gaps. And the Medigap companies don't really make decisions about what's medically necessary or not. They just base their decision on whether or not Medicare pays. So it will not step in and cover you in the situation where Medicare does not, unless it's one of the extra benefits for, say, extra days in a particular setting that Medicare doesn't cover. It's a type of program associated with Medicaid called the Medicare Savings Programs. These, particularly here in the district, are very important to keep in mind because if you come across clients who are eligible for these programs, they can go a long way towards paying premiums and associated cost-sharing amounts. Well, the next few slides, just really quickly take a look at those before we get into these last two issue areas. Medicare Advantage plans, private Medicare plans, also known as Part C of Medicare, and Medicare Part D prescription drug benefit. So Medicare savings programs, very quickly, these are programs that if individuals are eligible for them, can pay some of Medicare's premium and cost-sharing amounts. The most generous as far as the scope of coverage of these three different programs is this first one, the qualified Medicare beneficiary. The numbers that you see appear in these next three slides are all based upon the federal floor that federal law provides. Many states states can make eligibility criteria more generous. For example, these Medicare savings programs have both income and resource or asset coverage criteria. A lot of states have done away with any resource or asset criteria. Here in the district, as Andrew will talk about, instead of 100% of federal poverty level, which is roughly $11,000 a year in income, the District of Columbia has increased the eligibility threshold to 300% of the federal poverty level, which again is very generous in comparison to a lot of other places and is certainly worth taking a look at.
The Medicare savings programs then generally are only available to people who are dual eligible?
Well, the question is, are these Medicare savings programs only available to people who are dually eligible? And the short answer is no, although not for dual eligibles who have full Medicaid. That's people who have these programs are sometimes referred to as dual eligible because the Medicare savings program is considered a Medicaid type program, but it is not a criteria that someone has full Medicaid in order to be eligible for these. And a lot of times the eligibility criteria for these programs are more generous than any given area's Medicaid criteria. So we look to this. I think you first look to see if someone's eligible for Medicaid, because that's going to be coverage in addition to coverage of services in addition to coverage of cost sharing and things like that. I think then if that person's not eligible, you take a look at some of the Medicare savings programs. But no, it's not a prerequisite that someone be eligible for Medicaid. But just be aware that these programs are considered in some ways to be associated with the Medicaid program. So sometimes someone will say dual eligible and actually refer to someone who has Medicare and one of these programs, when really I think the term is probably better applicable to people who have full Medicaid. Medicare Advantage, Part C of Medicare. Roughly almost a third of all Medicare beneficiaries are enrolled in private insurance products known as Medicare Advantage plans. These Medicare Advantage plans, or MA plans, are offered by private insurance companies. They are approved by Medicare, and they provide alternative ways to get coverage through Medicare. Unlike the Medigap policies that we just touched on, Medicare Advantage plans do not supplement traditional Medicare Parts A and B. Instead, they replace it. If someone enrolls in a Medicare Advantage plan, he or she gets their Medicare coverage through that plan. They do not alternate. They cannot say, I'm going to go and use my Medicare Advantage plan for this services, and then I'm going to go back to traditional Medicare for this service. They are usually in a plan and must get their services through that plan. Because there are caveats and exceptions to everything, it is worth mentioning, because I think there is a plan here in DC, a type of Medicare Advantage plan called a cost plan. And these are these hybrids that actually do allow people to use both Medicare Advantage and in some cases go back to traditional Medicare. So in addition to the question, what type of coverage do you have? If the answer is Medicare Advantage, ask what type of Medicare Advantage plan. And if you're dealing with Medicare Advantage plan here in the district, it's worth your while to check out and see whether or not it is one of these cost plans. I think Kaiser might offer a cost plan here in the district, but it's worth checking to see, because that, if a person is in one of those plans, that changes the equation as far as any outstanding bills, because you might be able to actually get a bill paid for through traditional Medicare. So another wrinkle, just in the back of your mind, in your notes, Medicare Advantage, write down, is it a cost plan? And then that's another bit of research you might want to do. And I hope that after this, people don't walk out of the room in frustration and say, why did I ever sign up for this? There are too many permutations, it's too complicated. It is too complicated. But if it's complicated for us, imagine how complicated it is for the folks that you all are here today to try to help.
Because you're saying the Medicare Advantage plans do not supplement Parts A and B, but replace, why then you have to be enrolled in Parts A and B? I'm confused.
The question is, if Medicare Advantage plans do not supplement traditional Medicare, but instead replace them, why does a person have to be enrolled in Part A and B anyway? And the notion here is that Part A and B are really the core of the Medicare program. You have to have Part A and B in order to be in a Medicare Advantage plan. You have to continue to pay your A and B premiums. Most people pay their Part B premiums. The way Medicare Advantage plans get paid are, the Medicare program pays a capitated amount, per member per month to that health plan. If Andrew enrolls in a Medicare Advantage plan, I'm Medicare, I pay that plan $700-800 a month, a set dollar amount, to cover all of Andrew's services, whether or not he's never been sick a day in his life or he has 13 multiple chronic conditions. Andrew has to keep on paying his Part B premium because I, the Medicare program, had to get something from him. He has to pay into Medicare. He has to continue his Medicare coverage. And Andrew can't go back to traditional Medicare. He still has Parts A and B, and he still has to pay his Part B coverage. But because he's chosen to enroll in that Medicare Advantage plan, he has to get his care through that plan. But I, as the Medicare program, I'm not gonna allow Andrew to drop his Medicare Part B. Medicare doesn't get any more money that way. They don't get the monthly premiums, and at the same time, let him enroll in a Medicare Advantage plan and pay that capitated amount every month. So that person has to have that core A and B coverage and has to continue to pay for that core A and B coverage, even when they're in a Medicare Advantage plan, even if that Medicare Advantage plan also charges an additional premium. Because there are benefits and there are advantages and disadvantages of Medicare Advantage plans. A lot of them charge premiums in addition to traditional Medicare for services that they provide above and beyond traditional Medicare in general. Some of those Medicare Advantage plans offer Part D prescription drug coverage. They combine the services, and oftentimes you can enroll in a Medicare Advantage plan and get Medicare Part D prescription drug coverage and not pay as high a premium as you would for such coverage if you just enrolled in a standalone Part D plan. So Andrew has to retain his Part A and B coverage, or he becomes ineligible for Medicare Advantage. Does that help?
It still seems, okay, in principle I understand,
Right.
but it still seems unclear.
But seriously.
I'll leave that a rhetorical question.
Yeah.
Yes, ma'am.
Seriously, Medicare Advantage is generally detained additional coverage that may not be available on the regular Medicare.
Are you saying if someone is in a Medicare Advantage plan, do they need additional coverage, or
No, no.
is it a
that
way?
why a person would go to
Okay, yeah,
a medical
that's a
advantage
great
program?
question, because there are both advantages for joining a Medicare Advantage
Yeah.
plan and disadvantages that I think we'll cover in a minute. Considerations, yeah. Let me walk through the next few slides, and if you still have that question, ask it again, because I think it's a lot of people want to know, why should I enroll in a Medicare Advantage plan? It works for a lot of people. A lot of people love Medicare Advantage plans. As I like to say, some people swear by them, other people swear at them. Largely it depends upon how you want to access your health services, what you want covered, whether or not you're comfortable with a restricted network of providers, how often you use services, and it really is a personal decision. Having said that, a lot of people don't have a choice. A lot of people, if they want retiree coverage that's provided by an employer, they'll have to enroll in a Medicare Advantage plan. That constitutes a good chunk of people in a Medicare Advantage plan. If I want this extra benefit I can get through my former employer, I have to do this. I have to enroll in these plans. But most people seek out Medicare Advantage plans on their own because they find it more cost effective. Maybe there are extra services that are covered by that plan that aren't covered by traditional Medicare. But a lot of people avoid them because they don't want to be restricted to a particular network of providers. Maybe they've encountered problems trying to access services. When they become sick, they find that they run into all these barriers trying to get care through their plan. So there are advantages and disadvantages, and it is largely up to that individual and his or her preferences.
I just want to add on to that for 1 second too. It's true, I think, in many cases that people may seek out the Medicare Advantage plans. It's also true, and we have at the Legal Aid Society seen this. I think it's been a little bit less of a problem recently, but over the past 5 or 6 years, we saw examples of the Medicare Advantage plans very aggressively marketing themselves to people who were enrolled in traditional Medicare, and signing people up without fully explaining that you would not have access necessarily to the traditional Medicare network. You would have to go to the doctors that are just in your Medicare Advantage plan. And so we do caution people about signing up for Medicare Advantage plans, and I think one of the reasons that we do that is because the QIMBY guidelines in DC are so generous that there is a very generous cost-sharing assistance program for people who are in Medicare and also low income in Washington, DC. So a lot of the costs that are associated with Medicare can be avoided by that community. And one of the ways that the Medicare Advantage plans market themselves is to say, we'll save you money, we'll be less expensive, but they don't really go into the details of what that means. And so, people are obviously free to make whatever decisions they want, but we caution them to be very careful and to maybe talk to someone like us or someone like, David or someone, who really understands these programs before they sign up for Medicare Advantage, especially in DC.
Generally, Medicare Advantage plans are required to cover the same things that traditional Medicare covers. All the services we just walked through under Parts A and B. But depending upon how they structure their plan and their plan bids and their contract with Medicare, they often also provide services that people can't get through traditional Medicare. So whether it's extra preventive services, some Medicare Advantage plans waive that whole 3-day prior hospital stay that, pretty much negates that observation status issue. Most plans reduce the cost sharing that is required of individuals. Instead of that 20% coinsurance for Part B services, there's set co-pays for certain services or deductible amounts. Medicare Advantage plans can charge different co-payment amounts, coinsurance, and deductibles for certain services in relation to traditional Medicare within certain parameters. The plans have to structure their benefits in a way so that they are not discriminatory against individuals with certain health conditions, meaning, say you have diabetes. The plan can structure their benefits in such a way so that you as a person with diabetes would be paying exorbitantly more than you would under traditional Medicare. There are actuarial equivalency tests that essentially mean at the end of the day, you as a Medicare Advantage enrollee can't be charged more than someone in traditional Medicare. And also, some Medicare Advantage plans offer Part D prescription drug coverage. These are known as Medicare Advantage prescription drug plans. And not mentioned on the slide, now all Medicare Advantage plans have a cap on out-of-pocket expenses, something that does not exist under traditional Medicare. This is known as a maximum out-of-pocket limit. This year, the maximum out-of-pocket limit for Medicare Advantage plans is $6,700. So they have to impose a cap of at least that much. But remember, hardly anybody has just Parts A and B of Medicare. Most people have Medicare plus something else. So a lot of people, in effect, have out-of-pocket caps. But Medicare Advantage plans now have to impose them as part of their benefit packages. Eligibility for Medicare, despite the comments made there, I know that it might not seem fair, but people do have to have both Part A and B of Medicare in order to enroll. They have to continue to pay their Part B monthly premium. They must live in a service area. And here's the bit of legal discrimination that we touched on earlier. The one group of people who can be prohibited from enrolling in Medicare Advantage plan are persons with end-stage renal disease or kidney failure. As with everything else, there's some exceptions to that. Particularly, most often when a person had employer-based coverage before they were eligible for Medicare, had end-stage renal disease while they were in that plan, and then are transitioning to Medicare, and that same insurance company offers a Medicare Advantage plan, so sometimes those people could just pass right through and enroll in a Medicare Advantage plans. A few other narrow exceptions. But this is really, I think, still remains a quite unfair and discriminatory rule. Everyone else, though, cannot be excluded based upon pre-existing conditions. They can't be charged more based upon their health conditions. Medicare Advantage plans must take all except for people with end-stage renal disease. There are different types of Medicare Advantage plans. By far the most common one is an HMO, Health Maintenance Organization. I think most of us are familiar with them. A network of providers provide services. Usually you go to a primary care physician who serves as a gatekeeper through whom you have to get referrals to see specialists. Preferred provider organizations generally allow people to go outside of a network as long as they pay a little bit more for going to see providers outside of a particular network. Special needs plans, which are limited to individuals who are dually eligible in certain places, individuals with certain chronic conditions, or individuals who are institutionalized. I'm not sure if there are any special needs plans in the district right now at this time. Private fee-for-service plans, one of the worst ideas in health policy in the last couple decades. Thankfully, they're on their way out, but it's a hybrid kind of plan that allows someone to enroll in a plan and go to any provider that's willing to take them. The problem with these plans are that an awful lot of providers were unwilling to take people with those plans, so you could be enrolled in a plan in an area where absolutely no one would be willing to treat you. And the same rules about networks didn't apply. change in the law now requires these plans in areas where they are offered, where there are at least 2 HMOs, essentially, they have to provide networks too. These plans are on their way out. Medical savings accounts, extremely rare in Medicare. I think they're only offered in a few places in New York and Pennsylvania. They operate kind of like a health savings account that combines a high deductible before that you must meet before your plan kicks in with a bank account into which the Medicare program deposits money that you can apply towards meeting that deductible. Again, for whatever reason, these haven't taken off. They're not available largely across the country. But just know they take different forms. Almost always, you're going to be dealing with an HMO. Some of the considerations that we talked about, some of the advantages and the disadvantages include that these plans are on annual contracts. They renew their contracts with Medicare every year. They can alter their benefits. They can improve their benefits. They can decrease their benefits within certain parameters. Beneficiaries are locked into those plans for the most part for the whole calendar year. If you love your plan, great. If you're having a lot of problems with your plan, most part you're stuck for the rest of the year. They have different benefits and cost sharing amounts that you need to really, if you're considering one of these plans and you have the choice over the different types of plans, really need to consider how you want to access your services and what your cost sharing amount might be. Plans can terminate their providers from their network during the year. It's a big issue in Connecticut for one of the largest plans there. Advantages and disadvantages. Finally, Medicare Part D, the prescription drug benefit, began in 2006. The only way to get Part D prescription drug benefit is through enrolling in a private plan. That's the only real benefit through Medicare that requires you to purchase private insurance. You can either get it through a plan that offers nothing but prescription drug coverage. These are known as standalone Part D plans or PDPs. Or you can enroll in one of those Medicare Advantage plans that offers prescription drug coverage. Those are known as MAPDs. This is the chart of the standard Part D drug benefit. Just like the caveat I gave about all the cost sharing we went over with Parts A and B of Medicare and that most people don't pay that amount, this is the basic structure of a Medicare Part D plan benefit package. It's the floor, the baseline that Part D plans have to offer. But again, most people are not in plans that look like this. This is the floor, the base that the plans have to provide, but they have some flexibility to alter the benefits a little bit. So often you'll see like no deductible, but cost sharing higher in other places. In short, after meeting a deductible for a plan, there are 3 levels to Part D prescription drug coverage. An initial coverage limit, the coverage gap, also known as the donut hole, and I know there's a more appropriate way to spell donut, it's D-O-U-G-H-N-U-T, but for our purposes it's D-O-U-G. And catastrophic coverage. Once you meet a deductible, you enter your initial coverage period during which a beneficiary is responsible for 25% of the costs of a covered drug, 100% of the costs of a drug that's not covered. If you reach a certain amount in cost sharing, your coverage then disappears. You fall into what's known as the donut hole, where you are responsible for 100% of your costs unless and until you reach that 3rd level of coverage. If you have expenses that are high enough to reach a certain level, then your coverage kicks back in that 3rd level known as catastrophic coverage. It does not make sense. It has confused people since it has come out, but this is another, just like that 2-year waiting period for individuals with disabilities to get on Medicare. It was set up as purely a cost-saving mechanism. Because if these plans provided continuous coverage, it would cost that much more. The Affordable Care Act, aka Obamacare, closes this gap in coverage over time so that by 2020 there will no longer be this donut hole or gap in coverage. I gave up trying to understand this structure a long time ago. This next slide talks about what the Affordable Care Act does. It phases how it's closing the donut hole. There are different cost-sharing amounts required of people based upon whether or not they're getting brand name or generic drugs. Again, the hole will be closed completely by 2020. Part D plans have some flexibility in what they offer. They can within certain parameters, set and change their own formularies. They all use what are known as utilization management tools. These are barriers that the plans can place with respect to accessing covered prescription drugs. It includes requiring prior authorization, it includes quantity limit, it includes therapeutic substitution, and a number of other mechanisms that the plan can use to try to limit access to particular drugs, to ensure people are taking the right drugs, and to try to steer people towards trying certain drugs before they try the drug that they want. Plans can have tiered co-payments. They could put drugs on different tiers. For example, generic drugs will have the least amount of cost sharing. There'll be different tiers that go up in the amount of cost sharing, and they'll have specialty tiers where you pay a considerable amount for a very expensive drug. And there are some rules that allow you to appeal for drugs that are in a higher tier to go down to a lower tier with some limitations. For people who need drugs that are not covered by their Part D plan, there are some mechanisms to try to appeal for coverage of those drugs. If that person is unsuccessful or their situation does not meet the criteria for appealing those drugs, then they pay 100% of the cost of the drugs that's not covered by their plan. Plans also charge monthly premiums. National average is around $32 per month. It's often cheaper if people do get those plans through a Medicare Advantage plan. Similar to the Medicare savings programs, there is something known as the Part D low-income subsidy, also known as extra help. If an individual qualifies for the extra help program, or LIS, that will go a long way towards paying their cost-sharing amounts. I'll let you guys look at this on your own time. The last slides in here are all citations to where you can find Medicare law, regulations, and sub-regulatory guidance. I'm out of time, but I'm going to take one more minute to say there are 3 topics that are covered in the chapter that are not covered in these slides. I encourage you to take a look at the chapter that's included in your materials. That has to do with Medicare summary notices, or MSNs. These are statements that Medicare sends out about coverage that they have been billed for, and it's a really important tool to determine what an individual is responsible for and what Medicare covers. It applies in traditional Medicare. Medicare appeals, there are some links in the material, in the chapter, that lead you to more kind of layman explanations with citations, I think, of the Medicare appeals processes and the different stages. Those are important to know if you're going to be assisting those folks. And then finally, the concept of balanced billing, of a couple paragraphs in the materials that talk about physicians, participating, non-participating physicians, and what that means for the amount that they can charge. With that, I, of course, ran out of all my allotted time, plus all my Q&A time, plus the extra 20 minutes I got at the beginning, and I'm just warming up. Thank you, everyone, for your attention.